I'm Melissa Kirk. I'm a student at the Mississippi University for Women, and I'm going to be going over dyslipidemia and coronary artery disease. Alright. I'll be going over the objective, what dyslipidemia is, the lipids, incidence of dyslipidemia, risk factors for dyslipidemia, and the risk for coronary artery disease. By the end of this presentation, the learner will be able to develop a clear understanding of the definition and description, incidence, and the risk factors associated with dyslipidemia. The learner will be able to use clearly defined information obtained from this PowerPoint and be able to obtain awareness and the education necessary to properly provide awareness of dyslipidemia. And the learner will also be able to potentially decrease the occurrence of coronary artery disease and other conditions manifested from dyslipidemia. These objectives are according to the SMART outline. Okay, what is dyslipidemia? Dyslipidemia is defined as an abnormal amount of fats or lipids, which are cholesterol, triglycerides, or both, in the blood. Dyslipidemia is a contributing factor in the development of coronary artery disease and atherosclerosis, which is the development of plaque inside the artery walls. Alright, the lipids that are measured in the blood are the high-density lipoproteins, or the HDL, or also known as the good cholesterol. The higher the levels of HDL, it reduces the risk for coronary artery disease. The low-density lipoproteins, or the LDL or bad cholesterol, increased levels of these increase the risk for coronary artery disease. And then you have your triglycerides, and increased levels have been linked to increased risk for heart attack and stroke, but increased levels do not, the higher the level, you have to have certain conditions with the high level of triglycerides to be, or to get a heart attack or a stroke. Okay, these are the cholesterol numbers that are considered healthy, borderline, and high risk for developing cardiovascular disease. It just goes over what's normal, what's optimal, what can be high, or what's high, and what is very high. And this is just something to look at and go by in order to help determining your risk factor for coronary artery disease. The incidence of dyslipidemia. The incidence of dyslipidemia in the United States is high, with the majority of adults being affected by some form of lipid abnormality. Levels of lipoproteins and lipids, particularly LDL cholesterol, increase slightly as people age, which can result in dyslipidemia. Levels are normally higher than in men than in women, but women's levels tend to increase after menopause. An estimated 53% of U.S. adults have lipid abnormalities. 27% have high LDL, 23% have low HDL, and 30% have high triglycerides. 21% of these have mixed dyslipidemia, which means they have 2, which is high LDL with either low HDL and or high triglycerides. The risk factors for developing dyslipidemia are categorized into two different categories, primary and secondary. The primary are the genetic or the hereditary causes, and the secondary are the lifestyle and other causes. Primary dyslipidemia, it tends to be hereditary and it runs in families. Cholesterol and triglyceride levels tend to be higher in people with hereditary dyslipidemias. The tendency for HDL to be unusually low can be inherited, and the consequences of hereditary dyslipidemias can include premature atherosclerosis and coronary artery disease, which can lead to heart attack and stroke. Secondary dyslipidemia. Consuming a diet high in saturated fats, trans fats, and cholesterol, having diabetes, being physically inactive, consuming large amounts of alcohol, smoking, or using certain drugs such as estrogen when taken by mouth, oral contraceptives, corticosteroids, retinoids, thiazide diuretics, cyclosporin, HIV, AIDS, antivirals, beta blockers, and anabolic steroids. Foods that are high in saturated fats include like cupcakes and flour and refined sugar type foods. And then the other ones would be, the good fats would be like peanut butter, avocados, salmon, beans, legumes, that kind of stuff. Okay, once dyslipidemia is determined, your risk for coronary artery disease is, total cholesterol is only a general guide to the risk for coronary artery disease. Increased LDL increases the risk. Decreased HDL, which is less than 40 milligrams per deciliter, increases the risk. And triglyceride levels above 150 milligrams per deciliter are considered abnormal, but not at risk for heart attack and stroke unless there is a low HDL level, diabetes, kidney disease, or family history of coronary artery disease, which is what I was trying to explain a while ago, how about the triglyceride being increased. All right, dyslipidemia and the risk of developing coronary artery disease, which leads to heart attack, stroke, and death, is a big concern. The incidence among adults in the United States should be alarming to many. Efforts to increase awareness of dyslipidemia and decrease the resulting risk of coronary artery disease should be intensified among healthcare leaders. Thank you.
Hey, my name is Morgan Miller and I'm a student at the MUW BSN program. Today we are going to talk to you about dyslipidemia coronary artery disease. Just some objectives. By the end of this presentation, hopefully you will have learned what the pathophysiology of this disease is, some signs and symptoms, and some how to diagnose it, and hopefully the prognosis. The pathophysiology of dyslipidemia is just basically abnormal cholesterol or fat levels in the blood. Most of these will be elevated, and dyslipidemia eventually can lead to coronary artery disease. Now, what coronary artery disease is when plaque builds up in your arteries and it can cause a decreased blood flow. Here is just a picture. Here is a normal artery. So there's nothing here blocking it. And then here is a plaque buildup artery. You can see how you only have about half of the artery that is being able to pump blood to your heart. And here's the plaque right here. So this one is getting normal blood flow, and this one is getting a pretty good amount decreased blood flow. Some signs and symptoms to look for. Sometimes you can be asymptomatic. You don't have any signs and symptoms whatsoever. Basically, they'll only find it just because they were doing a routine health check. Some other signs and symptoms you can have are chest pain or angina, which chest pain can be characterized as a tightness in your chest, a pressure, a heaviness. It can be dull, it can be sharp. It can also radiate to your arm and your jaw. Another sign and symptom is shortness of breath, And most of the time when you're having that chest pain, it's more than likely that you're having a heart attack, so make sure you go to the ER. Another sign and symptom is tachycardia. So how to diagnose this? You'll get blood lipid levels. That we're going to check your cholesterol. You'll just go to the lab, get some blood work done. That's it. Like I said, most of the time these levels will be elevated. Another way to diagnose is with the EKG. How you'll tell with the EKG is basically because when your blood flow is reduced and ischemia occurs, your ST segment could be depressed. It will most likely be depressed, or your T-wave inversions are noted. The ST segment can return to normal once your heart is getting the normal blood flow back. An echocardiogram, what that is just an ultrasound of your heart. We'll use that to determine your EF, ejection fraction of your heart, and a stress test. That can be a nuclear Lexi scan, a dobutamine stress test. Then you also have a cardiac catheterization. Now what this is basically they'll go in through, normally they go in through your femoral artery. They'll just kind of go in, shoot some dye into your arteries, and they'll have it on the screen, so they'll be able to see how well the dye is pumping. If it will show a blockage or stenosis in your heart, or in the arteries. This is the best way to diagnose CAD. It would also show the presence of arteriosclerosis. And with the cardiac cath, the patient may receive a percutaneous transluminal coronary angioplasty. What this is, it will just kind of be a little balloon which will compress the plaque against the walls of the artery to dilate the vessel, so your blood will be able to flow. They might also get a stent placed, and you can also diagnose with a heart scan, like a CT or something like that. Now this is just showing how they stent. Here is your clogged artery, and this is what they go in. This is the catheter that I was talking about. They would go up through your artery. They'll with the balloon and the stent around it. They'll blow up the balloon and pull, and deflate the balloon and pull it out, and it will leave this stent. The stent just stays expanded, so your blood flow can flow normally. Prognosis. An estimated 15.5 million people in the U.S. have coronary artery disease. Each year, 1.5 million patients suffer from acute MI, and more than 600,000 people can die from this. It's always better to just have your routine health exams so that they can diagnose it early and it can be treated early. Okay, that is it. Thank you for listening. Now Abby Smith's going to come up and talk to you.
Hey, I'm Abby Smith. I'm also in the MUW BSN program, and I'm just going to talk to you about dyslipidemia and coronary artery disease. So by the end of this presentation, I hope that you'll learn the ethical issues concerning CAD, along with the impact of the disease process on the patient, family, and their social interactions. Okay, some ethical issues. Patients that are unable to afford medications, they just never get them filled, or they get the samples from the doctor, and then after those run out, they just don't ever go back and get them filled because they can't afford it. Another ethical issue is patients might deny the medical care they need because of religious issues, such as if you do need a cabbage, if the heart disease gets so severe that you need a cabbage, Jehovah's Witnesses won't be able to do that. And then some patients can't afford the heart healthy diet. The heart healthy diet would be an aim to decrease the serum cholesterol and the triglyceride level, which is like a low fat, low cholesterol diet, which is typically more expensive than if you would go to like McDonald's and get off the dollar menu. Is the healthier option is a little bit more expensive. Okay, living with coronary artery disease. Effects that heart disease can have on life. Heart disease is a lifelong illness. Once you have it, you can't get rid of it. You just have to kind of live your life around the disease. It's truly a life-changing condition. It alters the physical, social, and emotional aspects of your life. Some physical issues. Some patients that are diagnosed with heart disease will have to decrease their physical activity to decrease the workload of the heart. Now, if they're used to doing strenuous activity, they might just have to stop a little bit and do a little bit lighter activities. And with this it might depress the patient, knowing that they have the disease and they can't do everything that they used to do. Some emotional issues. CAD may cause anxiety, fear, and stress. They just might be worried about their heart problems. They might have anxiety about their social changes, their lifestyle changes that need to be made. And having depression or anxiety will aggravate the condition of the patient. So it's very important that you provide not only physical care, but also emotional support for the patient during this hard time. Social life and heart disease. Patients who usually enjoy drinking alcohol with their friends will have to stop. This also includes social smoking or either smoking in general. We advise you not to do that. Some patients' heart disease is so severe that they actually have to stop working because their heart cannot manage the extra physical work. And this can also be a damper on family, because if this person was the income provider of the family and now they have to kind of cut back, that might kind of stress things out a little bit more. So if they have to stop drinking, they're not used to going out and have, drinking and smoking, then that could cause depression because now they don't have very much social interaction. So the best way to resolve this is to let them join organizations with patients having the same conditions that they have. Support options. There's patient support groups. If you can't actually go to one, if your community don't have this support group, there's multiple ones on the internet you can find. So it's just easier if you are around a group of people that have the same symptoms, so you can kind of learn ways to cope and release some of the anxiety about it. Family support is also a very huge deal. You need family support. It will help reduce stress and anxiety. So with family, they can kind of, work with this patient or this family member that has CAD. They can help them quit tobacco or be an emotional support for that. They can be more active with them, and they can also, as a family, choose better nutrition. Tobacco smoke and stress increases blood pressure. The physical activity can help lower cholesterol levels, help with blood pressure. All this is just overall helps with the condition, or minimizes it. So this is it. Thank you for listening. I hope you learned something.
5, 4, 3, 2, 1. My name is Tori Johnson. I'm a student at MUW, and I will be discussing the care plan for dyslipidemia and coronary artery disease. The objectives are, by the end of this presentation, the students will learn common problems associated with coronary artery disease, learn how to manage symptoms related to coronary artery disease, and gain knowledge about different disciplines that help treat coronary artery disease. Ten diagnoses for the plan of care are acute pain, and that's related to the decreased oxygen supply to the heart. Activity intolerance, that's related to the imbalance between oxygen supply and demand. Imbalanced nutrition, more than body requirement, related to excessive intake of calories, sodium, and fats. Ineffective peripheral tissue perfusion, that's related to the interrupted blood flow. Deficient knowledge and balanced nutrition, more than body requirements. You should assess their body weight, teach them how to decrease dietary intake of fat, teach them how to limit their dietary intake of cholesterol. The goal for the patient would be to demonstrate behaviors, lifestyle changes to recover and or keep appropriate weight. Other disciplines that can assist the patient is the dietitian and labs. Labs to monitor how well the cholesterol is. Ineffective peripheral tissue perfusion. You need to assess the pulses of the patient, assess the temperature and color of skin, assess patient for the report of numbness and tingling, provide oxygen as ordered if it's needed. The goal for the patient will be to maintain maximum tissue perfusion to vital organs as evidenced by warm and dry skin, present and strong peripheral pulses, and absence of chest pain. Other disciplines that can assist the patient are the cardiologist and respiratory therapy. Deficient knowledge. You should assess the patient's readiness